Welcome to the Doctors Hospital Distinguished Lecture Series. Every month we invite members of our medical community to speak on topics that matter to you, the Bahamian public. We trust that you will find this information useful. Now sit back, listen, and learn. Isn't your health worth it?
I'm an interventional pain management physician. How many of you know what that is? Okay, good. That's a good start. Interventional pain management, you'll find out in a couple of slides, it's a newer field in medicine. It's about 50 years old, okay? We're talking about obstetrics and gynecology and having babies, it's hundreds and thousands of years old, right? But interventional pain is about 50 to 60 years old. And even when I trained, I finished my interventional pain management fellowship, I'll show you, at Duke University Hospital in North Carolina 15 years ago. And when I trained, Duke Hospital is a huge hospital. I mean, it's probably about, I want to say maybe 10 times the size of doctors, okay? And at that year, there was only 2 of us in the whole hospital. Now they're up to 10 fellows, but you normally have to do go to medical school first. I did that in Ohio, and then do a residency training in anesthesia or related field. I did that in University Hospital in New Jersey. And then you go back, then you go additionally and do 2 more years in interventional pain, okay? So that's what makes me an interventional pain fellowship trained doctor. Okay. I have about, as you know, 14 years of experience. I see patients right now in Florida, primarily. My consulting company and my practice is called Premier Pain Management. I was at VI Pain Management for about 9 years prior to that. My associations are the American Society of Interventional Pain Physicians, Florida Society of Interventional Pain Physicians, and because I'm an anesthesiologist also, American Society of Anesthesiology. All right, so let's talk about pain. What's pain? Pain is probably the most unpleasant sensation you could ever have, yeah? And what causes the pain is usually an injury to your body. You either have a disease process, or actually when some people have emotional disorders, you feel like you're in pain. Pain can happen 3 different kinds of pain. SVN. Somatic pain is sharp pain, like if I cut my arm, okay, that's somatic pain. Visceral pain is if my belly hurts. And neuropathic pain, who has diabetes in here? Anybody know somebody with diabetes? Okay, so people have burning in their legs and their feet, that's called neuropathic pain, okay? So that's 3 kinds of pain. Pain can also be pain that happens now. So I cut myself, it's acute pain. Or pain that happens now but keeps going and it doesn't heal as quickly as we think it will heal. That's called chronic pain. And that usually lasts at least 3 months or so, but it's really pain that lasts longer than we think it should for what the problem is. So if you bump your arm and you still have pain 2 months later, that's probably longer than it should be. I'll skip that slide. So the question, if we know what pain is, because pain hurts, what is interventional pain management, which is the kind of doctor I am? She's confused too. All right, I mentioned earlier, it's a newer specialty. It's the 34th specialty in medicine. When you have pain, you normally go to either a primary care physician, your regular doctor's office, this is after you do everything at home, like ICIT and everything else, or you go to the emergency room. Somewhere between the emergency room and you needing some kind of procedure done, something needs to happen in between. And an interventional pain management doctor, that's where we come in. Between actually having your initial treatment with your primary doctor where they gave you a Motrin, a Panadol, or something like that, or actually having surgery, there's an interventional pain doctor that can provide services you might need in between. And we'll talk about what those services are, okay? All right, the number 1 pain I see, if I see 30 patients a day, 15 of them have low back pain, okay? And sciatica. Who heard of sciatica? Raise your hand, okay? So sciatica is caused from your back, even though it's into your legs, but it's caused from your back pain. I also treat neck pain, bad shoulders, hips, knees, and ankles, diabetic neuropathy. We talked about nerve pain, muscle pain and spasm. Sometimes muscle pain can, you have a muscle spasm and your back hurts because you lift a heavy box. Sometimes that can bother you too. Arthritis. There's something called complex regional pain syndrome, which I won't get into today because there's a complicated syndrome and it's very, very unique. We treat that. Anybody know someone who's had surgery and they still have pain? Okay, that's called post-surgery syndrome. There's a name for that, and I treat that too. We have people who have shingles. Anybody know any older people who have shingles? Yeah. So I treat patients who have shingles, and whiplash headaches is called occipital headaches. This is your occiput in the back of your head, and when people have whiplash, they have occipital headaches. All right, so let's talk about low back pain. Low back pain is the most common reason why people go to the doctor. Okay. It costs about $50 to $100 billion a year for you to treat lower back pain because everybody seems to have it. There's causes. There could be bodily causes. They can be, also want to know what tests we use to treat it and what kind of therapy. All right, so if it's a body cause, what could cause your pain? All right, well, we're talking about lifting a box. So if you lift a box and you hurt your back, that's your muscles. Okay, if your friends or your brother or sister can touch your back and feel it and you go out, it's more than likely your muscle because they can feel the muscle around your skin. There's these things called ligaments and tendons that are deeper. Everybody knows what a joint is, right? Your knee joint, your hip joint. There's bone, also bone pain. You can have bone pain. A lot of times we see bone pain in cancer patients. Lastly, there's also nerve pain. We discussed nerve pain also. All right, so the question is, you have this muscle pain or this nerve pain, you have sciatica, and you went to the doctor. The question is, how do they know what test to give you and when to give it to you? How do you know who gets the test, and how do you know what test to order? So we'll go over that. All right, so you have pain. The first thing a doctor does isn't let me order a test on you. The first thing they do is say, okay, well, they listen to you and say, where's your pain? They might give you a 6 to 8 weeks, 1 to 2 months of Panadol or Motrin or Aleve or Advil or something, give you some physical therapy and see if you get better. If you don't get better, then we start talking about, well, let me do an additional history and physical. Let me find out how old this person is, if they had another disease process. Is something else going on with them? A lot of times people can have something else that's causing the pain they're having. For example, patients who have gallbladder problems also have shoulder pain. We call that referred pain, okay? You guys have heard the commercials, like, if you're having a heart attack, your arm might hurt. Okay, it's not because the heart hurts your arm, it's because it's referred pain, okay? And people who have hip pain may also have pain in their groin area. They might present with pain in their groin area. So we gotta think about the lifestyle of the person, what their goals are. If a person has back pain and they're telling me, well, I garden for a living, or I'm an architect or a carpenter. At Duke, we took care of the NFL players, so they have to go. We have to get rid of their pain as soon as possible because they were going back in the field the next day, regardless of what we did anyway. All right. So what do we order? So that you had pain now. It's been 2 months. The doctor gave you a Panadol. It didn't help you. You had some physical therapy. It helped a little bit, not a whole lot. What kind of test would we order for you? Okay. You can get an X-ray. An X-ray shows bone. You can get an MRI. Who has heard of an MRI or had one? Okay. MRIs show deeper tissues. So it shows all the stuff we talked about before, the muscle, the ligament, the tendons, the things that can cause pain. The MRI shows that. And so does a CT scan. The other ones are a lot more provocative, a lot more complicated, but everybody's seen an ultrasound machine because we've seen women who have having babies have ultrasounds. We can also use the ultrasound machines now to diagnose pain. They're really complicated and fancy now. All right. So here's a list of a bunch of procedures that I do. Means nothing to you unless you have it, but we'll stick with the shoulder, hip, knee, joint injections. Anybody else have knee pain, joint pain, shoulder pain? You guys understand that, yeah? And that kind of pain can be treated from some of the injections that we do. But there's a whole lot of other things that we do also. All right, what do? We use, for interventional pain doctors specifically, the tools that I use include a fluoroscope. What this is a video camera and an X-ray machine combined, okay? And it's attached to a TV monitor. So if you are under this and you wiggle, I can see your skeleton wiggling on the screen. If I put my hand in front of you and I do this on top of your back, I can see my hand on top of your skeleton doing like this. So it's a video camera and an X-ray at the same time. We also see ultrasound. We also use ultrasound, and you guys know what that is also. We talked about that. Okay, so let's talk about patients. Mr. Smith, he's a 46-year-old man. He had a 10-month history of lower back pain. He began after he lifted boxes at work. He's having pain in his back. It's going down to his buttocks, down to the back of his legs at the level of his knee. Okay? On exam, I noticed that his pain was not relieved by standing up, but by leaning forward. Okay, and when he stood up and rotated his spine like this, like he's dancing, he had pain then. Okay, so that's Mr. Smith. The question is, what's going on with him? Mr. Smith has a disease we call facet osteoarthropathy, arthritis in his facet joints. Okay, that's the long word for arthritis, by the way. See the ART right there. Okay, so what we do for Mr. Smith is I'll show you what a facet joint is. This is a facet joint. This is a cartoon of it. So this is your head. That's your bottom. On the sides of your body right there are these joints called facet joints. Now, how do we know they're joints? Well, the medical definition of a joint is the space between two bones, okay? So I have a lower leg, a thigh, I have a knee joint. I have a hand, I have a forearm, I have a wrist joint. So when two bones come together, they call a joint. So who likes oxtails in here? You guys eat oxtails? Yeah. Me too. All right, that's my favorite. Okay, so this looks like an oxtail right here. And so does that one, because that's kind of what it is. And in between them is the facet joint in everybody's, okay? And they start here, that's one oxtail and two oxtails, that's one there. That's two there, three, and they go all the way up on the sides of your spine. Those are called FACET, facet joints. Questions so far? All right, so what I do is under that big machine you saw that's an X-ray and a video camera, I go in and I actually go into the facet joint with a small needle. And because I can see what I'm doing when I'm doing it, because again, it's a video camera and an X-ray, I go in and put pain medication in here to stop the pain from happening. Okay? Now that is done under local, and it takes about 2 minutes to do it. Okay? Literally, you can count to 120 and it'll be over. And I've done this on my mother before, and you guys know, okay? All right, so if I do it on my mother, yes, so that's usually your test. This is what it looks like. When you look under the X-ray machine, that's a video camera, this is a picture of it. That's the facet joint right there. Does anybody notice it looks like a dog? You see it? We call it the Scotty dog, okay? So that's how you know you're in the facet joint, because it's right there. This one is the dog again, and it's right there, okay? But you realize it's kind of the oxtail coming together. All right. All right, so after you do that, and the patient says, well, Dr. Victor, that was really, really helpful. My pain is gone 80%. But then they come back 2 months later and say, well, it's starting to come back again. The next thing you can do is what they call radiofrequency denervation, a big word to say you can actually go in and take pulse, like microwaves, and actually buzz that nerve and stop it from hurting the patient. Okay, it's called rhizotomy. That's the big word for it. Radiofrequency denervation is also called rhizotomy, R-H-I, rhizotomy. All right, case 2. Okay, in medicine, the differential diagnosis is what could be her problem. Okay, anybody want to guess? It's sciatica. All right, so she's absolutely right. It's sciatica because pain in her back going down her legs, and we've seen that before. The question is, what causes sciatica? Does anybody know? True. You guys have both. She said pinched nerve. He said man put a wallet in his pocket, and you both are right actually, because there's more than one reason for sciatica. Okay, and your reason with the wallet in the pocket, here comes, piriformis syndrome. Okay, so sorry I'm in your way. Piriformis syndrome causes sciatica because the piriformis muscle is located right in your buttocks. Okay, do you see it? It's this one right here. All right, and the nerve in everybody comes down from your back, down your buttocks, down your leg. But this muscle, when it spasms, it squeezes the nerve as it's coming down the root. It normally comes down, and it shoots the pain down your leg. And that's why the guys in the wallet in their back pocket is pressing on the actual muscle and pressing on the nerve, and that's why they have sciatica. Okay? So there it is again. This is your bum. Okay? This is the nerve coming down. It has multiple ways it can do it. It can go underneath, around, in between. But whatever happens, you spasm or you squeeze that nerve down, and that's what you get. How do you know a patient has that versus having, you said a pinch disc? Because you do this exam on them. The moment you cross their one leg over the other, can't do that in high heel shoes, like this, you have to engage that muscle to do that, and it hurts like mad, and they start having pain, okay? That's called the thigh cross exercise. There's a reason for that. All right, so what do? You take a needle, and you stick it in their bum, literally, and you put it in this area, and you put an anti-inflammatory, and you relieve the pain. It looks like this on their X-ray. That's called piriformis muscle injection. Okay? All right, so this particular patient did not have piriformis syndrome. We did an MRI and we found what she just said. We found a herniated disc. So what's that? All right, same sciatica, but this time it's starting from up here. This person's back to the oxtails. This person's back, and between them has these things you call discs. Have you guys ever seen this or heard of this before? These are your shock absorbers of your body, your sponges, okay? Because if you didn't have these, if you didn't have those right here, these bones, the yellow ones, would rub together like teeth. So you would be about this high by the time you were 10 years old because they would just keep chopping away at each other. So God, or whoever you believe in, but God, put these things in between to cushion the bones from knocking against each other so you're not like this high and keep eating away at each other like your teeth would be. All right, so what happens, these discs right here, they start sticking backwards, okay? Because they're normally a half circle, like how you look nicely right here. They start sticking backward and doing that. That's what you call a herniation, okay? So you guys ever heard the word hernia before? Like a hernia? That means it's sticking out, right? So that's herniation of a disc. It's sticking out. And this is, if I lie you on your back, this is what it looks like, sticking out there, okay? Questions so far? So when that sticks out right here, what happens next is it presses right there on this yellow thing. But what's that yellow thing? That's your sciatic nerve, okay? So you either catch it down in the bum or you catch it up here, but you can catch it, okay? All right, so treatment for this is what they call an epidural steroid injection. There's two different ways to do epidurals. Okay, so the number one question I get, is this the same procedure I get when I'm having a baby? All right, so the answer is no, okay? The epidural is a space, a location in your body. For example, if you say somebody is having a knee injection or a knee replacement, you guys know the difference between a knee replacement and a knee injection, right? The thing they have in common is your knee. So the epidural space is a space, a location in the body, not the actual procedure. The procedure is actually called a subarachnoid block, okay, in real life. But we call it epidural because it's a street name for it, a regular name for it. All right, so this is what it looks like. Under the x-ray machine, this is what an epidural looks like. So I can do it straight in the middle of your back under x-ray guidance, or I can do it from the side. That's from the side. But it gets to the same location, which is that nerve. Remember that nerve that was going down the bum? Right there. There it is. It's highlighting it with the dye, okay? All right. There's another condition, and just for showing for you guys, that causes the same kind of pain in the buttock area, shoots down the leg. It's called your sacroiliac joint pain. So the sacroiliac joint is where your back meets your buttocks, right in here. And that's here, okay? And that can also cause the same pain that it's sciatica, it is a sciatica pain, but it's really not. It just looks like it. Okay, so we do fancy things too. So sciatica aside and all kinds of things aside, in interventional pain medicine, we kind of do some fancier things. So what do? Well, we talked about people who had back surgery before or any kind of surgery, and now they're still having pain years later. Well, people like that, you can't really give them another surgery. I mean, sometimes they've had 2 or 3, actually. So what you do is you put in a thing called a spinal cord stimulator in their backs. That looks like that, okay? It's about the width of the end of my little tiny fingernail, because I don't have any, right there. And you put this stimulator in your back. There's a complex mechanism, but this stimulator helps relieve the pain. It basically sends signal to, let me explain to you. When you have belly pain at home, you know you do like this? Or you have a headache and you start tapping your head or you hold your head really hard? Okay, so you're activating beta-2 fibers in your body. That's your nerve fibers. You're telling your brain to stop the pain by doing this. So this does the same thing. So it sends signals, but in your back area, okay? The same concept as like holding your belly if you have pain. It's complicated, but that's one of the things we do. There's newer advancements, because that one's kind of old. That's about 20 years old now. When I trained, it was 5 years old, but you know, as I get younger, it's getting younger too. All right, newer advancements in pain or interventional pain medicine are the following. All right, so you remember we had a herniated disc a little while ago? And we did an epidural. What if the epidural didn't work? We gotta go in and get rid of the disc that's sticking out because the epidural is not causing it to shrink enough, yeah? So we can do through your skin, this little device goes through your skin after we numb it up, and we actually can pull this material out through the device. That's what it looks like. And it sucks it out and puts it all inside of here. Okay? That's called a percutaneous disc nucleoplasty. That, again, this thing is no bigger than, I don't know, it's smaller than a hanger as far as the width, a metal hanger. It's very thin. Your earring, the back of your earring. That's what it looks like, okay? All right, so in addition to that, there's a new extension of medicine in every field, but a lot of it in pain management, interventional pain, called regenerative medicine. Have you guys ever heard of regenerative medicine? No? Okay. Well, I'll explain what it is briefly, very briefly. Regenerative medicine is your body normally, when you have an injury, okay, you want your repair to be more than your breakdown. But not everybody, you know, some people, you know, they hit their knee and they never get better. But some people do. Some people have a headache that keeps getting worse, or some people have back pain and it doesn't get better. Not everybody's balanced like this. Not everybody's repair is as higher than their breakdown. So, this is the norm. This is what your body should be doing. But when it doesn't break, when it doesn't heal, it looks like this. See that looks nice and organized, and this does not. Okay. So what we do now is we have procedures where we take patients' own blood out of their hand, we spin it down using a centrifuge, okay? We get this yellow part that has the growth factors that tells your knee, you need to form some more cushion for me, okay? As opposed to just injecting you. That's called platelet-rich plasma. You take your own blood, spin it in this machine, it looks like this, you pull this part out and inject it into the patient's knee. And then the cells of the cushion, which is called your cartilage, start growing back, okay? Because this part of your blood is actually where it has what they call growth factors that causes your tissue to grow. Okay, so stem cells are cells from your bone marrow, okay? These are cells from your blood. So stem cells happen before your blood. So you use your bone marrow, which is like, you know, you go into your bone. You guys had chicken legs before, yeah? The thing inside the bone is the bone marrow, right? So before you can get to the blood, your bone marrow forms your blood cells, and then they become when you get cut, what you bleed. But the stem cells are before you even get to blood, so they're earlier on, okay? They call undifferentiated cells, meaning that they haven't figured out if they're gonna be blood, teeth, or what they're gonna be yet. Okay, so they catch them there. So they can grow quicker, and that's why they use them, okay? So it's the same concept, yes, okay, the same vein. Another thing people do, anybody had, this is called, highly recommended, it's Synvis. Anybody had Ultravis or Synvis? Anybody know anybody that had it? All right, so these are products that they have on the market now that you can inject in people's knees, and they cause like the cushion to be a little more rubbery, okay, and it helps stimulate growth also. All right, so he had it, and so did Kobe Bryant. They both had it on their knees, and there's who likes basketball here? Okay, so everybody knows who that is, right? Okay, good. And actually, Kobe had it twice. Kobe was one of the first NBA players that had PRP, and he had it injected in his knees. All right, we'll skip that. All right, so this is the part that you guys will be interested in. A lot of my practice of medicine, because I've been doing this long enough now to know that I don't know as much as the patients do, is really patient-focused and purposeful results, meaning that every time a patient comes into my office, I give them a questionnaire and discuss with them as a result not only why you're here, but what can we do for you in your lives to make you feel that you're more productive and you feel better. Let me say what I mean by that. Some people are housewives, okay? They need to be able to lift their children and cook and wash dishes and do all kinds of things, okay? Some people are contractors. They need to jackhammer. Some people are NFL players. Some of us sit down all day long at a computer. Some of us walk around. So the question is, if you have pain in your back, your knee, your hip, what level of pain would you need to decrease for you to start being able to do what you'd like to do again, whether it be work or your personal life, gardening, exercising, things like that. So I always ask patients, I always tell them, okay, on a scale from 0 to 10, if 0 is no pain and 10 is really bad pain, like sticking your hand in boiling hot water, what number would you want your pain to be and still tolerate it and call it, and call it being decreased? Everybody says 0. And I always say, okay, don't be greedy because God is paying attention, right? So from 0 to 10, which number is the least number that you can get and feel like you're out of pain, okay? And I get somewhere around a 3 or 4 for most people, okay? And when they're not being greedy, okay? So it's important that you we direct as physicians the care based on each patient, because each patient is different, okay? Some people's goal is to exercise, okay? Some people's goal is to bend in their garden. Other people's goal are to, stand on the stove and cook long enough for their families. There's so many different. I had one lady came in the office. This was not Puerto Rico. This was the Virgin Islands, and she came into my office for the first time. She came from another country, and she came into the office. And she said to me, this is about 10 years ago, I can never forget. She says, Dr. Victor, I said, yeah. She says, you have to fix my back because I'm about to get a divorce. Okay? I said, well, that's a lot of pressure. I just met you, So everybody has a different reason why they need their pain fixing, okay? That's the point I'm making to you guys. So you got to really based treatment. And this is not only pain management, just treatment in general of patients based on what the patient's actual needs are for their lives, because we all do different things, yeah? All right, so questions that I ask patient, okay? The pain has changed. What has the pain changed in your life? Pain has changed blank in my life, okay? So pain, in her case, was her intimacy with her husband. If you feel better, you would like to do what? Everybody wants to exercise and lose weight. I think that's the number one answer. If I felt better, I'd lose weight. Now, the problem with that answer is I go back and ask them when they're feeling better how much they exercise. And I give them an exercise sheet to tell me how much they exercise. So that's the problem. I actually hold them accountable to the answer, okay? Because you have to hold people accountable. They just can't tell you any old thing, okay? What percent of pain relief would make you feel like you, this is the God question. What percentage of pain relief would make you feel like you'll be able to accomplish a goal? And don't be greedy, don't say 100%. All right, and this is what my questionnaire looks like, okay? Would you like to do acupuncture, massage? What lifestyle goals would you like? What kind of employment do you have? So this is actually a copy of my questionnaire in my patient's form, okay? And they fill this out because this is important. I go back to this every time I see them. I say, okay, well, did you do any of the goals that we talked about in the beginning? Yeah. You talked about if they eat red meat, how much vegetables they eat, and don't tell me you want to lose weight and I have 4 steaks this whole week. I mean, that's not the way it's going to happen. And I have them talk about what they eat for breakfast, lunch, and dinner. I give my patients meal suggestions. If they want a protein diet versus a plant-based diet, I actually give them menus of different diet options and different food options, because sometimes people just don't know what would taste good and can't think of recipes themselves or what to make, So helping them out a little bit is good. And then they get used to it and they start doing their own thing too. Because we have what? Google. All right, in conclusion, interventional pain medicine and regenerative medicine have been, fields are involved. There's technological advancements that have assisted in doctors being able to visualize, like the fluoroscopy machine I showed you guys, the treatment and the targets. Evidence-based medicine supports this, and it's now accessible and affordable, okay? Because there used to be a time where this treatment wasn't that affordable for patients. And this is pretty much me. That's it. Thank you guys for your time.
We hope you've learned a lot from this edition of the Doctors Hospital Distinguished Lecture Series. Please join us in the Loudon Conference Center on Dowsville Street every 3rd Thursday for the monthly health talks, where you can feel free to ask your questions. Isn't your health worth it?